Welcome back, registrars. Look, I know exam prep can feel absolutely overwhelming, like drinking from a fire hose, right? So today on The Explainer, we are bringing some serious, enthusiastic energy to a highly visual, top-down anatomical dissection. And this is built specifically for your board exams. We're strictly prioritizing the visual clarity of these spatial relationships today, how these structures physically sit together, and more importantly, what that actually means when a patient is sitting right there in your chair. We're going to lock down those cold recall facts and immediately connect them to clinical reasoning. Let's get into it.
Okay, let's dive right into our anatomical funnel. Today, we're covering 1. The bony orbital walls, 2. Neurovascular gateways, 3. Extraocular muscles, and 4. The anatomy of the sclera.
Section 1. The bony orbital walls, specifically the floor and medial structures.
Whenever you're dealing with orbital trauma, your clinical spatial reasoning has to start with these rigid, completely unforgiving outer walls. We group these bones together to make cold recall basically effortless for you. So for the orbital floor, just remember MZP. That's the orbital plate of the maxillary, the orbital surface of the zygomatic, and the orbital process of the palatine bones. Right? MZP. Now for the medial wall, moving anterior to posterior, it's M, L, E, and L-WAS. That's the frontal process of the maxilla, the lacrimal bone, the orbital plate of the ethmoid, and the lesser wing of the sphenoid. Now pay really special attention to the orbital floor here. It's distinctly separated from the lateral wall posteriorly by the inferior orbital fissure, and running forward from that fissure, right at the midpoint of the floor, is the infraorbital groove.
Now, here's a classic high-yield board question for you. Based on the structural map we just went through, which of the orbital walls is the absolute thinnest and the most fracture-prone? Well, if you were visualizing the medial wall, specifically the lamina papyracea of the ethmoid bone, you are absolutely correct. Nailed it. You need to anchor this anatomical fact directly to the clinical presentation of ethmoid fractures. Think about it. When a patient takes a blunt force injury to the eye, this literal paper-thin medial wall just blows out. And that is exactly why you'll see clinical signs like orbital emphysema. You get air escaping from the ethmoid sinus directly into the orbit, causing that characteristic crunchy crepitus when you palpate the eyelids.
Moving on to Section 2, fissures and neurovascular gateways.
So funneling down from those rigid bony walls, we reach the really complex, high-stakes wiring that passes from the intracranial space right into the orbit. Now, one of the most absolutely crucial bony landmarks you need to know here is the optic strut. Defined with uncompromising precision, it's the posterior root of the lesser wing of the sphenoid bone. Its sole job in this orientation is to act as a bony bridge that physically separates the optic canal, which is above and medial, from the superior orbital fissure, which sits below and laterally. So logically, a lesion destroying the optic strut, well, that's going to compromise both of these massive neurovascular gateways simultaneously. Not good.
Take a really close look at the crucial spatial relationship at the superior orbital fissure and the optic canal. The extraocular muscles actually anchor themselves to the common tendinous ring, which you probably also know as the annulus of Zinn. You can clearly see how this fibrous ring divides the superior orbital fissure into distinct, separate compartments. And listen, knowing exactly what goes where here is just non-negotiable for localizing orbital lesions on your exams.
Now, what's really interesting about this is how cleanly we can break down the geography of this space for your cold recall. Let's look inside the annulus of Zinn first. You've got the heavy hitters in there, the optic nerve, cranial nerve 2, passing via the optic canal. Then you have the superior and inferior divisions of cranial nerve 3, cranial nerve 6, and the nasal ciliary branch of V1. Got that? Okay, now let's look outside the ring, but still passing through the superior orbital fissure. Out there, you'll find cranial nerve 4, the frontal and lacrimal branches of V1, and the superior ophthalmic vein. So clinically, if a patient presents with a swollen orbit and isolated palsies of the structures inside the ring, but they've got spared frontal and lacrimal nerve function, boom, you can localize that compression specifically to the space within that tendinous cone.
Right below that, we've got the inferior orbital fissure. This is essentially a gap between the greater wing of the sphenoid and the maxillary bone, and it serves as the main connection between the orbit and the pterygopalatine and infratemporal fossa. It transmits the infraorbital nerve and vessels, as well as the zygomatic nerve. But oh man, here's the board favorite trivia you just cannot forget. This fissure is actually bridged by periorbita and an evolutionary leftover. Yep, a vestigial smooth muscle with absolutely zero real function in humans, known as the orbitalis, or Mueller's muscle. And please do not confuse this entirely useless muscle with the superior tarsal Mueller's muscle in the eyelid. They love to trick you with that.
All right, let's keep it moving. Section 3,
extraocular muscles, and adnexa.
Let's shift our perspective to a more anterior view of the orbital cavity to see how this all builds together. You can map out exactly how tightly packed the extraocular muscle origins are right around those fissures we were just discussing. The four rectus muscles arise from that annulus of Zinn we just analyzed, creating this muscular cone that just perfectly encapsulates the optic nerve and the ophthalmic artery as they enter the orbit.
But of course, there's one major exception to this posterior origin rule, and they absolutely love testing it. The inferior oblique muscle does not originate at the apex. No, it originates anteriorly, right behind the orbital rim on the maxillary bone. And from there, it takes a highly unique path. It passes backwards, laterally, and superiorly, specifically sweeping right beneath the inferior rectus muscle to insert on the posterior inferior lateral aspect of the globe. Understanding this specific spatial trajectory is absolutely vital when you're conceptualizing things like strabismus surgery or orbital floor blowouts, where this whole muscle complex can so easily become entrapped.
And finally, Section 4, Anatomy of the Sclera.
So we're funneling all the way down from the orbit into the globe itself now, focusing our attention purely on that rigid outer fibrous coat. The crucial point here is knowing the variable thickness of the sclera, literally down to the millimeter. So the sclera is thickest posteriorly at exactly 1 millimeter. Then it's about 0.8 millimeters at the limbus, thinning out to 0.6 millimeters at the equator. But look at this final measurement. It is at its absolute thinnest, a mere 0.3 millimeters, immediately behind the insertions of the extraocular muscles. So clinically, why does this matter so much? Well, if a patient suffers severe blunt globe trauma, this ultra-thin 0.3 millimeter zone right behind the rectus muscle insertions is the prime site for an occult posterior globe rupture. You have to know exactly where these structural weak points are.
Structurally, the sclera's viscoelastic nature gives it incredible tensile strength with very limited distension. This is what preserves the shape of the optical components against intraocular pressure. But you know, its relationship with the nervous system is equally important. Posteriorly, the sclera extends back to the optic nerve, where it doesn't just stop, it actually actively fuses with the dural and arachnoid sheaths at the posterior scleral foramen, right around the lamina quibrosa. And this continuous anatomical fusion is exactly why elevated intracranial pressure transmits directly to the optic nerve head. It really connects the dots on why patients develop papilledema, doesn't it?
To wrap up our explainer today, I want to leave you with a somewhat provocative synthesis question to test the clinical reasoning we've just built. Based on the strict anatomical boundaries we've reviewed today, how does an orbital apex lesion clinically differ from a superior orbital fissure syndrome? Think about the optic strut and the annulus of Zinn we looked at earlier. A superior orbital fissure syndrome knocks out cranial nerves 3, 4, 5, 1, and 6, which causes ophthalmoplegia and numbness. But an orbital apex syndrome? Well, because the apex actually includes the optic canal, an apex lesion is going to give you all of those exact same cranial nerve palsies, plus optic neuropathy and vision loss. It all comes back to the anatomy. Keep visualizing these spatial relationships, and you are absolutely going to crush these concepts on your exams. Good luck studying, and I'll see you next time.